Good afternoon, ladies and gentlemen, and welcome to our program this afternoon, Lung Protective Ventilation in the ICU. So for this afternoon, I am privileged to be your host, and of course my partner, Anne, here. So,
สวัสดีค่ะ
so good afternoon again, and today we are more than privileged to be joined by two professors that will teach us on the topic on lung protective ventilation. So without further ado, our first guest, of course, all the way from Sao Paulo in Brazil, Dr. Marcelo Amato, he is currently affiliated with Pulmonology and Intensive Care Medicine of the University of Sao Paulo. His main areas of expertise is research on protective mechanical ventilation, electrical impedance tomography, and technological solutions for mechanical ventilation. Anne?
So welcome all the doctors to this big event today. My pleasure to see all the key doctors throughout Thailand, and especially my pleasure to see you, Dr. Marcelo and Dr. Napplika. You are really kind to us for coming today. May I introduce Dr. Assist.Prof.Napplika Kongpolprom. She is working at the Division of Pulmonary and Critical Care Medicine, Chulalongkorn University Hospital. And then I hope that today you will all enjoy our session. The first session will be start with Dr. Napplika. Dr. Napplika will talk about gentle lung fluid and will also show us the workshop. And then afterward, the presentation will be performed by Dr. Amato. Then that time we will have coffee break. After coffee break, we will come back for the interesting wrap up and discussion. I hope today you will be all enjoying the session. Thank you for coming. Welcome, Dr. Napplika. Welcome, Dr. Amato, sir.
Thank you very much for your introductions and good afternoon everyone. My name is Napplika and I'm great pleasure to be here today to present the gentle lung suit, a tool for recruitability assessment. And this is the outline of my presentation. And ARDS is the clinical syndrome with the decreased functional lung size. And for the pathologies of the RDS, which consists of the acute exudative phase and the collapsed lung with gravity dependence, and it causes the heterogeneity of the lung, and it causes the patients more susceptible for the ventilator-induced lung injuries, including barrel trauma, volume trauma, and thoracic trauma. And a lung protective strategy is a standard treatment for the patients with the ARDS. And for the open lung concept, it's possible to use recruitment maneuvers followed by the high PEEP to reduce thoracic trauma and shear stress in combination with the protective lung strategy. It helps to maximize the recruitment of the alveoli and minimize the cyclic atelectasis and thoracic trauma, and decrease the biotrauma from the alveolar collapse and minimize the denitrogenation, atelectasis, and oxygen toxicity. And the open lung approach consists of the recruitment maneuver that we have to use the high pressure to inflate the lung, especially in the dependent part of the lungs, to make the more homogeneity of the lung and prevent the lung injury. But it can cause the distension and can cause the lung injury as well. And it's should combinations with the PEEP, optimal PEEP, to prevent the cyclic opening and closing. And the recruitment maneuver is a transient, sustained increase in the transmit pressure, which go to end up the collapsed areas of the alveoli. And in the dependent part of the lungs, it's composed of the consolidations, and some part the aeration can be reserved, but can be restored with a higher pressure. But some parts we cannot open up, no matter of the higher pressure that we use. And because of the recruitment maneuver have both positive and negative effect, it can increase the oxygenation and lower rescue the adjunction therapy, but it can cause the hemodynamic compromise, and it can cause more lung injury from the over distension. And the clinical outcomes of the recruitment manual is still controversy. Some papers show that it increased mortalities from the recruitment manual. It comes from the several factors. For the types of the recruitment manuals, there are many types of the recruitment manuals, include the sustained inflation, size, or stepwise pressure, increment pressure. And for the sustained inflation, we usually use the CPAP 40 centimeter waters for 30 to 40 minutes, and most recruitment occurs in the first 10 seconds, with hemodynamic compromise occurring later. And for the PCV or incremental PEEP, it caused less the hemodynamic compromise. There was the animal models that compare the different kinds of the recruitment manual, sustained inflation and step up and stepwise increase in airway pressure with the different duration. And it found that sustained inflations and stepwise can improve the static lung elastance and viscoelastic pressure, but the stepwise increase in airway pressure less the biological impact, and the longer durations can have less damage of the lung. It means it's indicated that the stepwise increase of the pressure might improve the might minimize the lung injury compared with the sustained inflation, and the longer duration, the better outcome. And this is the study compared the sustained inflations with the incremental of PEEP and PCV, and it found that for the lung oxygenation and the regional compliance and gas distribution, the results were similar, but in the incremental of PEEP significantly improved the inhomogeneities of the lung compared to the sustained inflation and PCV. And for the slow moderate pressure recruitment maneuver, minimize negative circulatory and lung mechanic side effects. So the techniques that use the stepwise approach with the longer duration minimize the lung injury and minimize the circulatory effect compared with the sustained inflation and the PCV. However, the recruitment maneuver improved the oxygenation, but the clinical outcomes such as the mortality is not improved. It might be explained from the cardiovascular consequences or some the high heterogeneities among the trials. For the landmark trials, open lung approach, it showed that the open lung approach includes the recruitment manual and followed by the higher PEEP can improve the driving pressure and oxygenation after the procedure. But it's not shown the statistic significance of the mortality outcome. But in this study, it's underpowered because the study terminated before the achieve the sample size. Another trial is the ART trials. This study shows that the open lung approach with stepwise increase of the pressure increase the mortalities. It might be come from the study protocol that use the high pressure. The patients have some patients have to terminate before they achieve pressure, and some have the barotrauma or cardiac arrest during the procedure. And it might be there are many concerning issues in this study. This study have the high mortality rate in both arms compared to the previous study. and the morbidity and mortality temporarily associated with recruitment manual was not appear in other trials. And for the PEEP titration, is optimizing study compliance is the best way to set PEEP. And this study did not select the PEEP responsive patients to do the recruitment maneuver. Another study is a SPA lab study. This study have terminated before the completion because the result of the ART trials. But this study show that the mortality is not different between the open lung approach and standard treatment. It may be explained that in this study, the protocol accept the permissive hypercapnia that can cause, because the permissive hypercapnia, the patients have a less respiratory rate that minimize the air trapping from the high respiratory rate. It might decrease the ventilator-induced lung injury and decrease the barotrauma. That may be explained that why in this study don't have the significant impact on the mortality outcome compared with the other trials. And for the live study, it's compare the personalized treatment in the with the conventional treatment between the patients who have the focal and non-focal pathology. In the personalized treatment, they use the FiO2 PEEP table as the ARDS net network and use the recruitment manual as the rescue therapy. And in the non-focal lung morphology, they have the mandatory use of the recruitment manual in this type of patients. And for the clinical outcome, the survival at 90 days is equal, but there are about 20% of the patients have the misclassifications of the lung morphology. And if we do, if the subgroup analysis of the patients who get the right diagnosis and right group, the personalized therapy improve the mortality outcome. It indicates that if we select the right patients, the recruitment maneuvers and open lung approach can improve the clinical outcome in these patients. And there are several factors that affect the success rate and failure rate of the recruitment maneuvers. The patients who have the extrapulmonary origin, the patients who have more severe ARDS, have more benefit from the recruitment maneuver. And for the protocol, in the patients who have the chest wall elastin problem, they need a higher pressure to inflate the lung. And if we select the inappropriate pressure level, it might not see the effect of the recruitment maneuver. And for the PEEP titration, the protocol that we use for select the optimal PEEP to prevent the cyclic closing and reopening of the lung might affect the clinical outcome as well. And the patients who have the lower PF ratio, lower compliance, high death space, and the patients who have the decrease in death space and increase in compliance when increase the pressure from 5 to 15, increase PEEP from 5 to 15 centimeter water, have the greater potential for recruitment. And if we select the patients who have the high recruitability, that means that the aerated tissue can be restored from the higher pressure. It may be benefit from the recruitment maneuver. And the oxygenation is not a good surrogate marker for the for predict the high recruiter patients. And for recruitability assessment, during the COVID-19 outbreak, recruitment to inflation ratio is a popular use to predict the recruitability. And the low flow PV2 is also predict the recruitability. And today I would like to present about the gentle lung suit. It's easy to we can use to access the recruitability. It's composed of the incremental PEEP and decremental PEEP, and we use the PCV mode as the default mode, and we select the inspiratory pressure about 15. It's like a driving, limited to driving pressure to prevent the ventilator-induced lung injury. And in this procedure, it increased PEEP step by step, and each step is about 5 centimeter water, and we can select the maximum pressure. It can be 50 to 55. It depends on the chest wall elastance of the patients. And after achieve to the maximum pressure, the machines run the decremental PEEP, and it monitors the gain of the lung compliance and lung volume, and compare between the decremental limb and incremental limb. And it selects the PEEP that have the best compliance, and compare the lung compliance and the recruitable volume at the PEEP that PEEP level. And from the study of the Professor Amato, is an animal model study. It showed that the recruitability lungs have the more reduction in driving pressure and more gain in compliance. And there was a significant correlation between the gain in compliance and the reduction in the driving pressure. And for the minimal critical important difference of the driving pressure of 4 centimeter waters, the gain of lung compliance about 50 to 100% can predict is associated with the change of the driving pressures of 4 centimeter water. So it can use the gain of the compliance to predict the recruitability of the lung. And if the patients have the gain compliance or gain lung volumes more than 50%, these patients the recruitment maneuver should be performed in these patients. And this is examples. If we perform the procedure and the recruitable volume and the gain in compliance is higher than 100%, the recruitment maneuver should be performed. But if the 0% or less than 50%, we should not use the recruitment maneuver, and we should use just only the lower PEEP strategy. And if the patients have the high recruiter, which predict by the gain of the compliance or gain of the lung volume, we have to perform the recruitment maneuver. And after that, we select the optimal PEEP by do the decremental PEEP titrations. And after we do this procedure, the lung will collapse again. So we have to do the second recruitment maneuver to open up of the lung and set the PEEP that we select from the maneuver. And this machine, we have the recruitment maneuver protocol. And after achieve the pressure that we set, we do the titrations of we do the PEEP titration. And in this machine, it defaults as the volume control mode, as a decremental PEEP titration procedure, because it helps to prevent the overinflation or hypoventilation from the sudden change of the compliance. And this is a PEEP titration procedure. We can select the PEEP that have the best compliance and use this PEEP plus 2 or 3 to set at the optimal PEEP for the patients. Conclusions: recruitment maneuvers should be applied with caution during the early ARDS phase in the high recruiter patients, which can predict by the recruitability assessment. And gentle lung tool is a simple tool that can help you to access the recruitability of the lung. And thank you for your attention. And after this, I will show you about how to perform this tool in the ventilator.
Yeah, the monitor on ventilator will be showing on this TV. So if you can see from this, it's the real thing between 2 monitors.
Okay. And this is the recruitment assessment tool, recruitability assessment tool, recruitment manual, and decremental PEEP titration. If you want to access the recruitability, you choose the RA. And you can see that this is the ventilators protocol that we use, and this is the default protocol, but you can change. You should select the delta inspiratory pressures around 15, and you do select the first step of the PEEP by select the PEEP in the patient's ventilator setting. And you can select the maximum pressure that you want to do in this patient, and you have to evaluate the chest wall elasticity of the patients. If the patient is obese, you have to use the higher pressure. Mostly we use around 40 to 50 centimeter waters as the maximum pressures, and for the PEEP increment step, it uses 5 centimeters waters. And for the duration, it should be 30 seconds, but you can choose the shorter or longer. But if you use shorter, the harmonics will more compromise than the longer duration. And for the respiratory rate, you can choose around 15. And when you perform the procedure, you should select 100% of the FiO2. After you finish the setting, you press the start button. So the machine will perform the manual to the patients. And for the graphic, the upper part is the PEEP level, and the lower part is the compliance of the respiratory system compliance. And you can choose for the lung volume at this, and you have to wait to complete the procedure. And when the procedure do, you can see that the lung, especially in the dependent part of the lung, will be inflated by the higher pressure step by step that the machine provide. And the machine monitors the compliance and the volume gain. You have to select the PEEP level that the patients have the highest compliance at the decrement limit of the procedure. In these patients, you can see that at the PEEP level of 20, the patients have the high compliance and high volume, high recruited volume. So you select the compliance and the volume at a PEEP level of 20 and compare, and the machine will show the percentage of the improvement of the lung volume and the compliance. And you can see in the upper part of the graph, and you can see the percentage of the recruitable volume and the gain in compliance. In this case, it's around 29% and 33% of the compliance. It means that this is the low recruiter. The recruitment manual shouldn't be performed in this patient. But if the patients have the higher recruiter, you can see the recruitable volume and the gain in compliance higher than 50%. You can select the recruitment manuals from the machine. So you choose the RM and you set the protocol that you want to do. It's like the same as the recruitability assessment, and you press start. The machine will increase the pressure step by step until achieve the highest pressure that you set. And after that, you can see that the machine go to PEEP titration. You press this button and it switch to the decremental PEEP titration. And in the decremental PEEP titration, you can see that each PEEP step is just only 2 centimeters of water. is different from the recruitability assessment, and the recruitment maneuver is lower a PEEP in each step. And the machine will do this procedure and monitors the compliance during this procedure, and you select the PEEP level that have the best compliance. So for this graph, you can see that the best compliance is around 40 at the PEEP level of 19. So the PEEP the minimum PEEP that provide the maximum compliance is 19, and you can choose it as the optimal PEEP, and you can plus 2 or 3 centimeter water when you set to the patients. And that's all for the recruitability assessment tool in this ventilator. And do you have any questions about the tool? And would you like to try to do this tool in this machine? You can go to the machine and try to perform the maneuver by yourself.
Yeah, any volunteer, please feel free to come.
Question.
Dr. Nathida, please.
Be discussed then between these two.
I think you need to look all parameters that can predict the recruitability. If you have the discordance of the parameters, you have to do another maneuver to find the recruiter or non-recruiter. For me, because the recruitment maneuver can cause the negative impact of the patients, if the discordance, I prefer to not perform recruitment maneuver. And if based on the study of Professor Amato, I think the gain in compliance should be the best parameter compared with the gain in volume, because the study shows just only the compliance gain related to the reductions in the driving pressure. And I'd like to have the comments from the Professor Amato about this question.
Yeah, I could not listen to the question.
I'm sorry. Is that any chance to have a discordance between the volume gain and the compliance gain percentage? Is that any chance? And if it's happen, what do you prefer? Which one gonna be better to prediction the run recruitment maneuver? For me, I think if they have chest wall compliance high, it might be have the compliance change and that not much change of percentage as well. So I'm not sure which one is better.
Well, this is a very good question. So you are absolutely correct that we can use either a change in compliance or a change in recruited volume to assess recruitability. But there is a reason, and maybe we can focus on this afternoon on this topic, to believe that to have some quantity, to have a quantitative evaluation of the recruitability, the compliance gain is better, because the relationship between volume gain and recruitability is very non-linear and goes in directions that sometimes is unexpected. Let me give you an example. If you take a patient, a post-operative patient, let's say cardiac surgery, he has almost normal lungs, and you try to do some recruitability maneuver, the gain in volume is going to be among us, is going to be sky high. But maybe this represents only 15% of the parenchyma. Let's say you recruited only 15% of the parenchyma, but the gain in volume can be 1 liter or 1 liter 0.5. When you do the analysis by compliance, you understand that you are really gaining only 15% of the parenchyma, and then so then You understand my point? So to do a quantitative analysis, the gain in compliance is better, because it's really telling you how much % of the alveoli you are gaining.
Thank you.
Anyone else has a question? Please raise your hand. I can bring you the microphone. All right, please.
Yeah, thank you very much for your nice presentation. I'm Dr. Faisal from Indonesia. Related to recruitment maneuver, there are many strategies to do recruitment like this one that you present. But I want to know about the quantify this strategy about the, is it fixed to increasing the PIP step by step until 20, or is it possible to more increasing again 25 or 30 or something else, or just fixed to 20 until that we monitor the compliance? Is it right?
You mean that the highest pressure?
Yes.
I think it depends on the chest wall elastance that you determine in the patients. If you see that the patients have the obese or have the much ascites, you should set higher than the 50. But if you set the higher, the more complications such as barotrauma or hemodynamic compromise will commonly occur. It's very hard to tell that what is the optimum maximized pressure in each patient. And if you try to perform the procedure, but lung volume gain and compliance gain is not achieved to the 50%, and you feel that the lung is not expand because the patients have the problem of chest wall elastance, you can increase the highest pressure and monitor the change of the compliance and the recruitable volume again. I think if you have the controversial in the to predict the higher recruiter or low recruiter, you have to do another procedure such as RI ratio or PB2.
Anyone else, please? Okay, if there is nobody else, I would like everyone to clap the hand for Dr. Napplika for giving us the experience today. Thank you, Dr. Napplika, so much. And now, Dr. Marcelo, you are cordially invited to share us the experience on RA. Thank you.
Okay, thank you very much. And I think I was very pleased to watch this very nice introduction, I'm really impressed. Let's start. I will try to capture some points that were already touched by the previous presentation. Okay. So the title of my presentation intentionally is my personal journey. So how to reconcile lung physiology with the results, the bad results of the latest studies. The sequence of studies, they are very impressive. Let me just let's say remind you about this whole sequence that happened in the last 30 years. So we started here when we started the first studies in Brazil about lung protection. Then we published these results, but you see, almost a decade later, when Keith Hickling was starting to talk about permissive hypercapnia. And then something that people forget, in the same year, 98, we had 3 studies that about protective ventilation that were completely negative because, in fact, they were showing more side effects of reducing tidal volume. For us, this was a very bad time, because, just to give an idea, in our hospital, people started to use back high tidal volume. So it was a very crazy years. And then in the 2000, we had the famous study of the ARDSNet, which was very positive. And then intentionally, the ARDSNet decided to study PEEP and tidal volume in 2 separate trials. So they used the first one, the ARMA study, to show that low tidal volume would be good. And then the alveoli was just the study to show that high PEEP could be, let's say, could leverage the good results of low tidal volume. But as you may know, this study unfortunately was negative, as the 3 other studies, the French study, the Express, the LOVES, the Canadian, and even the United States based on esophageal pressure. This one was positive, but was a very small study, and the combination of all other studies were negative. And then finally, in the last years, you know, the ART, which we are going to comment, that was very negative. Then we had the EpiVent 2, the FARLAP that was mentioned in the previous presentation, and also the LIVE. The LIVE is the one that is trying to separate diffuse ARDS against focal ARDS. But all these studies in total produced more than 5,000 patients. And if you think about when we propose the protective strategies, we are talking about more or less four combined strategies. So reduced tidal volume, reduced driving pressure, higher PEEP, and permissive hypercapnia. If you think about the final result of the ARMA trial, everyone started only to reduce tidal volume. So this was what captured the mind of physicians around the world. Everyone was thinking about tidal volume. And then this, in a way, although I believe that this is a simplified strategy, was a history of success. Everyone started to adopt some level of protective ventilation. But then here, when we tried to achieve a better PEEP titration or higher PEEP strategy, it was just confusion. And we could not get the good results that we see in experimental studies. So this is the subject of this talk. Why the first part of the story worked, but the second part, which should be a better PEEP strategy, we could not achieve this result. And for me, this is the most important question we have now in mechanical ventilation. And to the point that I remember that people started to believe that, okay, you should not use recruiting maneuvers, you should not titrate PEEP, just put an empirical PEEP, low PEEP, and then people started to be very sloppy with PEEP. And I think the reason of this is this whole story, because we tried many different strategies and nothing was really a success. Let's talk a little bit about this study, because this was the most controversial studies. I participated in the initial design of this trial, and later on, when the trial started and I analyzed the first 100 patients, I knew that it would be a failure. And I was very concerned. and then the final result was just, let's say, a confirmation that the study was not well planned. It was very well planned in terms of statistical analysis, but not in terms of lung physiology. Okay, so very good statistics, but very bad lung physiology. And as you know, in this study, they had an increased mortality when we tried to apply lung recruitment and a better PEEP strategy. A hazard ratio of 1.2, which means that we increase mortality considerably, almost 15 to 20%. So maybe you have seen already this slide, but I like it to play over and over again, because this slide gives us one idea what is happening around the world. So the first line in blue represents the low PEEP FiO2 table of the ARDSNet. If you are using that table, you have to be on top of this line. So, for instance, if you are using 80% FiO2, your PEEP level has to be around 15. If we are using 40% FiO2, your PEEP has to be 5. So, if you are on top of this line, you are using the low PEEP FiO2 table of the ARDSNet. And this is the high PEEP FiO2 table that was used in the alveoli trial and also in the Canadian trial, the LOVES. So very different. And what is this? Is the average PEEP around the world. So, and this was taken from this epidemiology study in more than 50 countries, which means that people is not following the high table of the ARDSNet, the low table of the ARDSNet. They are using low PEEP, and that's it. That's it. So for me, this is very disappointing. And it's interesting to see the difference between countries. Let me give an example. This is United States. So you see all the points. Each point is one patient. This is the low PEEP FiO2 table. So if you look at this slide, almost 500 patients are on top of the line, and a few scattered patients are out of the line, which means that the Americans follow the protocol. The Americans follow the protocol. The French people, they don't care. They use low PEEP whenever they can. So it's impossible for them to follow any table. But on the other hand, the Brazilians, they did the other way around. Look at this. So we are using much higher PEEP than the low PEEP FiO2 table. And this is the control group of the ART trial. So the control group of the ART trial should be on top of this line. But then people who had some background that they should use a higher PEEP, which means that the Brazilians didn't follow the protocol, right? So this should be the control arm, but this is exactly what happened in the ART trial. So the control group is not exactly a control group because it's an intermediate PEEP level. So, but the intriguing part of this is that in animal studies, it's absolutely clear that PEEP can be protective. And for instance, this is the most famous slide around the world. And we can easily see that a little bit of PEEP of 10 improved the lung condition a lot, although we are using the same plateau pressure. So there is no question that a little bit of PEEP helps to protect the lung. So the rationale of using an ideal PEEP is still valid. All the mammal species, they suffer from ventilator-induced lung injury, and they present some benefit of PEEP. For every species of animal, we have studies showing that reducing lung stress by reducing tidal volume is good, and that using PEEP is good. So why we cannot prove this in humans? Why randomized trials cannot prove it? let me just give you an example that the clinical trials on mechanical ventilation, they are very complex. And this is what was happening in those years, 95 until the year 2000. I called the hard times. Why? Because we had our study showing that protective ventilation decreased by half the mortality. But the three larger studies, so more patients than this, were showing the opposite. You see, the control group with high tidal volume had lower mortality in all of them. So this was really bad in my hospital, because then they started to use high tidal volumes again, and I personally suffer a lawsuit in my hospital because I was doing permissive hypercapnia. So this was really a bad time in the history of mechanical ventilation. And then finally, we had the ARDSNet study that set up the idea, okay, you should really reduce tidal volume. Okay, when I saw these very controversial results, so 3 negative studies versus only 1 positive, I decided to go to each center performing the study and I asked for the data bank. And then I capture the daily measurement of airway pressures in those trials. And then I took it, all the data from individual patients, and I plotted here. So each of the studies is a different symbol. And then I put here peak pressure, risk of death, corrected for Apache and age. And then you can see a very striking result. So higher airway pressures, they were killing more patients. But individually, each of these trials, they were negative. How you can explain this? It's because in each of the trials, there was a lot of noise. And then sometimes patients in the control group, they were receiving high pressures, and sometimes the patients in the control group, they are receiving low inspiratory pressures. So this analysis here is what we call per protocol. And when they publish the results, they publish the intention to treat. So it's very different what physicians think they are doing and what they are actually doing. So it's very different. So, and people forget about this time and how difficult it was to prove that low tidal volume was important. I'm telling you this story because I believe that the same thing is happening with PEEP. Tidal volume is much easier to prove, but PEEP requires much more individualization. And this is why the story of PEEP is so controversial. But it's amazing how much this graph is similar to this one, which happens in animals. So this is coefficient of permeability, peak airway pressure. You see, it looks like the same picture. So, and finally, we had the ARDSNet study. And then forever, now this question of low tidal volume at least was adopted. And then I believe that a step further on this is to, instead of focusing on tidal volume, is to focus on driving pressures. But at least we know that we have to decrease the stress on the lung. Then the history of low tidal volume was a history of success. Then we have this clinical trial from from Jesus Villar, was also showing that reducing tidal volume improved survival. There is this trial that even using low tidal volume anesthesia, this reduces mortality. So 11 against 6.4. But here again, it's low tidal volume with some PEEP during anesthesia versus 11 against 0 of PEEP. And there was much less pulmonary complications. And now, during the COVID time, it's interesting. This is a study published by our hospital. They are showing that even for COVID patients, you can, let's say, forget a little bit the lung protection. So to be on the blue line, you have to really keep your plateau pressures below 30, keep your tidal volume below 8 mLs per kilogram. And in this case, patients were in the red line is patients that are in the first 24 hours of mechanical ventilation. One of these parameters is not under this strict criteria. So somehow tidal volumes were a little bit above 8 mLs per kilogram, and plateau pressures were around above 32. So in COVID, they had, even in the era of protective ventilation, and in our hospital that everyone was thinking that they were applying protective ventilation, you see a difference in mortality. So you have each, let's say, each mistake you do at the bedside, not following the rules, causes some damage to the patients. So this is true. So protective ventilation, even for COVID patients, was never so important. And so I think the devil is in the details, and especially for PEEP, how to individualize the PEEP and how to improve the prognosis of these patients. And I like to say that these details are not just the details, they are really important things that you do under mechanical ventilation. Which are the problems that we have in those trials? The first of them, I think we lack basic monitoring to check if we're really doing something that could be bad for the patients. Like in this situation, we just check the airway pressures that they were really applying and under standardized conditions. The second problem is the lack of physiological understanding. And I'm going to give an example. This is the ART trial. This is a patient in my ICU, which theoretically people should be should have a good training in mechanical ventilation. And this is a patient that was randomized for this study, and then we were recording using EIT. And look at, this is airway pressures, this is flow, and this is the electrical impedance tomography. As you can see, the patient has air hunger. You can see that the airway pressures, they drop below baseline PEEP during inspiration. And in many cycles, you have breath stacking. You can see here from the EIT that this is the only 2 breaths that were not stacked. And this is 6 mLs per kilogram, which means that these triple stacking breath was receiving 15 mLs per kilogram of tidal volume. And then when you look at the ventilator, these patients, they were ventilated using the servo eye. The ventilator was showing you exactly 6 mLs per kilogram of tidal volume. So the ventilator does not compute breath stacking because it resets the tidal volume each new breath. And so and this patient was receiving high PEEP. If you look at this number here, is 20. So triple stacking on top of 20 of PEEP is even worse. In fact, it's a disaster. And this patient later on had a pneumothorax. So we know now that clusters of breath stacking is the most damaging factor for a patient under mechanical ventilation. And this is still missing any good monitoring at the bedside. But let's now, I talked about the bad things about high PEEP, but let's talk about good things that sometimes people forget. This study was published in JAMA. It came from my hospital, and we were responsible for this study. In this study, we randomized patients after cardiac surgery presenting signals of acute lung injury to receive a higher PEEP with protective ventilation, with recruiting maneuvers, or the conventional PEEP of the institution, which was 8. Why we chose a PEEP of 13 as an average? This number could be increased only if the body mass index was higher than 30 something. Then PEEP was increased to 15. Because this was we titrated using EIT, and this was the average PEEP of this population of patients. The highest pressure achieved during the recruiting maneuver was 45. So 300 patients, and then this is a typical image of a recruiting maneuver. After applying the recruiting maneuver, we have a much more dorsal ventilation, showing that we reduced the dorsal atelectasis. And then this is a graph showing pulmonary complications from death, very, very severe complications, moderate complications. And then when we applied this strategy, we can see that we decreased everything, right? So all pulmonary complications decreased, and the result was very significant, and this is why they published in JAMA. And we presented in the opening ceremony of the Jean-Louis Vincent meeting. So this was a very positive trial about PEEP and recruiting maneuvers. No case of pneumothorax. Everything went in the direction that we were expecting. Patients, they reduced the length of stay, so 2 days less of stay in the ICU, 2 days less in the hospital. So this was a very positive study about high PEEP. The study was very carefully done, so every patient, we assessed with the leg raising maneuver if the patient could tolerate the recruitment maneuver. So we were very concerned about the side effects of the recruiting maneuver. And as you can see, during the recruiting maneuver, there was a small drop in blood pressure, but never below 60. So we very carefully followed the airway pressures. At the same time, in conjunction with these studies, we also performed additional experiments in animals to show that whenever we apply the recruitment maneuver and we successfully reduce the driving pressures, for instance, in animals, you can reduce the driving pressures by 8 centimeters of water using the same tidal volume, okay? These animals, they have exactly the same tidal volume as these animals. And look at the difference in the situation of the lung. This is the lung after lung injury, so all animals were in a very bad shape. And now they are going to be submitted to 48 hours to this strategy or this strategy. The same tidal volume in both, but here the average PEEP was 8, the average PEEP was 16, okay? And this is the result. So it was absolutely visible in macroscopic and microscopic evaluation. So when we applied an optimized PEEP for these animals, so there was much less lung injury. We have less production of collagen in the lung, less infiltrates of neutrophils in the lung, and even the PET images showed much less inflammation. So everything that is yellow here is very inflamed. And then when we applied the proper PEEP, there were many less neutrophils inside the lung. So, I think this idea of driving pressure applies very much to all the animals. So this is the study of the New England in patients, but it's absolutely true that in animals, if we apply a certain PEEP level that reduces driving pressure, we can be successful. Something that we learned in the last years is that when you have high driving pressure, this is also related to lung fibrosis. This study was performed in our institution, and then we had, for each patient, we had at least 2 CTs after the discharge of the hospital, and we were measuring lung fibrosis by CT. This is the study. What we found is that, for instance, if you measure vital capacity or if you measure the density of the lung in terms of CT and the average driving pressure in the first week of mechanical ventilation, there is an inverse relationship, which means that the higher the driving pressure you apply in your patient, the lower the lung volume 6 months later. So it means that this patient had more lung fibrosis. So driving pressure is not only important for inflammation, but it's also important for lung fibrosis. We can see here that when driving pressure was low, there was no procollagen in the blood, and when driving pressure was high, there was a lot of procollagen in the blood, and it was increasing along the time. So what happened in the last years is that we understood that a high PEEP strategy can only be good if you are causing a drop in driving pressure. If you are increasing PEEP and not causing any benefit in terms of driving pressure, forget about it. You are going to collect only the side effects. And so the other mistake we had during the ART trial is that they didn't do any pilot study to see how much they were reducing driving pressures. And this is the result. In the ART trial, this is why I told you, when we did the first analysis with 100 patients, we realized that the reduction in driving pressure was only 1 centimeter of water. Along the week, 1 centimeter of water is impossible to get any positive result because there is no effect size. There is no, so we increased PEEP, but we didn't get any benefit, in physiological benefit, except for oxygenation. But oxygenation, everyone knows that is not an important outcome. It's kind of cosmetic. So this is why I realized, wow, with this reduction in driving pressure, this trial will never get positive, and then you are going to collect the side effects. It's like making a study about ECMO, like Warren Zapel did in the past. He put patients on ECMO, but he kept the tidal volume exactly the same as before ECMO. Then the result was predictable. The mortality is going to be higher if you use ECMO, because you have now the side effects of ECMO and side effects of mechanical ventilation. And here the same thing. So you are increasing PEEP, collecting all the bad side effects of high PEEP, but you cannot have any benefit with this minimum reduction in driving pressure. So we know nowadays that any positive trial would need at least a reduction of 3 to 4 centimeters of water in driving pressure, because otherwise you need a sample size of more than 1,000 patients, which is impossible. So just to give you an idea, in our study in '98, the reduction in driving pressure between treatment arm and control arm was 40. In the ARMA trial was 8. And then they were successful when reaching 800 patients. If we think about a new PEEP study, we have to get this reduction in driving pressure. Otherwise, you have to randomize too many patients. And certainly, let me skip this. In the ARMA trial, it was impossible to achieve this side effect. And also many recent studies trying to understand if low tidal volume or high tidal volume below or above 8 mL per kilogram in patients without ARDS, if they are protective, because the compliance of these patients is very good, the reduction in driving pressure is going to be very small, and then all these studies, they have exactly the same mortality. And we published at the beginning of the last year an important study showing that the reduction in tidal volume is especially important if you have low compliance. If you have a good compliance, you have to give more sedation to reduce tidal volume, but you are going to reduce your driving pressure by just 1 centimeter of water, and then the benefit is going to be much lower. Let me skip this. And now, so how we can address this problem of PEEP? What I believe is going to happen in the next years. So first of all, I think I like it very much, the previous presentation, because you presented exactly the same meta-analysis I'm presenting here. Even after the publication of the ART trial, there is still equipoise. Why this is important? So equipoise means that there is a little bit suggestion of benefit. So the odds ratio is below 1, which means improved mortality of using recruiting maneuvers and PEEP. But it's equipoise, which means that it's impossible to decide which is best. But why this is important for us? It's important because if you believe in the physiological benefits of a recruiting maneuver, you are ethically okay in still using it. It's a procedure that is still ethical and has to be better studied in the future. And this is exactly what I believe. And just to give you some examples, during the COVID pandemic, we did lots of studies using EIT, using this recruitment tool that you have seen in the previous presentation, and checking how much the patients with COVID, they benefit from a high PEEP strategy. Why? Because there was this whole controversy about phenotypes of COVID patients, L phenotypes or age phenotypes, and then people, including our hospital, we are very skeptical about using PEEP in those patients because some publications were suggesting that these patients, they have huge amounts of overdistension if you apply high PEEP. So we tested this, and we did not only a study in our ICU, but we did an international collaboration to assess how much those patients can be recruited. What do we have seen? First of all, is that whenever we applied a proper PEEP in those patients, typically we could reduce driving pressure by 4 centimeters of water. And this can only mean that these patients are recruitable. Because if the patient that is not recruitable, if you increase PEEP, you are going to increase driving pressures. And for these patients, whenever we applied the proper PEEP, driving pressures dropped by 4 centimeters of water. Then, during the last years, also we did a study in post-operative patients, and we found that whenever we applied the ideal PEEP for each patient, I'm going to define what is ideal PEEP, we could reduce driving pressure by 6 centimeters of water, which is a lot. And look at this. The larger the body mass index, the larger the drop in driving pressure, which means that optimizing PEEP is especially important for obese patients. These are the patients that need PEEP the most, right? And doesn't have to be super obese. So if you have a body mass index around 30, which is very common during the COVID time, the average body mass index in my unit during the COVID time was 33, which means that in these patients I could reduce driving pressures by 6 centimeters of water by applying a proper PEEP strategy. And there is this very interesting publication that we did together with the Massachusetts General Hospital in Boston, because there they have a problem with the super obese. Look at the body mass index of this person, and look the small lung buried inside the body. So these patients, they are really big size patients. And what happened is that in these patients, they had massive amounts of atelectasis just because they are laying down in the bed. And then in these patients, when we started to apply a proper PEEP, we could reduce driving pressures by 5 centimeters of water. So again, proving this concept that there is a special population of patients that benefit from high PEEP. To say the least, at least any obese patient should receive a little bit higher PEEP and should be tested for recruitability. And then when they started to apply this strategy, they reduced mortality by half. So even in Boston, applying the best standard of care, when they started to apply this strategy of higher PEEP, they reduced mortality by half. So this paper was published in the critical care, which means that, you know, the history of PEEP is controversial, but there is some cases of success. And I believe that all the studies that are searching for an individualized PEEP, they have better chances of being successful. And is another reason to believe in this idea of individualization. This is the hazard ratio inside the ART trial. So how this works? This works more or less in this manner. So look, in the x-axis you have here the driving pressure, okay? And this is the hazard ratio of being randomized to high PEEP. For instance, if I enter the trial and my baseline driving pressure is 10, okay, 10. Then if I'm randomized to the treatment arm, to the high PEEP arm, I have higher chances, above 1, 20% more chances of dying. So if my driving pressure is low and I'm going to receive a high PEEP strategy, I'm going to die. But then if you pick up the patients with driving pressure above 15, they benefit from a high PEEP strategy. So this is, so we, looking at this information, you understand that at least there are two target populations for high PEEP and for testing recruitability. Obese and patients presenting a high driving pressure at baseline. So these are the patients that you should pay attention and test if you can do something a little bit better, especially assessing recruitability. So with driving pressures above 15, you have to do something. So you cannot say, oh, I'm okay because my tidal volume is 6 mL per kilogram. This is not enough. You have to do something to reduce further your driving pressures. And we did this in patients with COVID. So every patient received some monitoring. Typically, when monitoring with EIT, we search for the PEEP level of the crossing point of the collapsing curve and hyperdistension. In this particular patient, the crossing point was 18. Later on, we can discuss why crossing point makes sense. It's interesting to see that this PEEP level, individualized per patient, doesn't mean that we are increasing PEEP. In fact, if I compare the ARDSNet PEEP, low PEEP FiO2 table, and the individualized PEEP, you see that at least in half of the patients I have to decrease my PEEP levels. In other half I have to increase the PEEP levels. So it's not high PEEP, it's a different PEEP individualized for that patient. For instance, if the patient is obese, very likely he's going to receive a higher PEEP, but also there is some individual anatomy of the patient that dictates this. And in this trial, when we applied this individualized PEEP, compliance improved and stayed improved along the whole stay in the ICU. So it's a long-term benefit for these patients. And driving pressures, in general, they were 4 centimeters of water smaller during the whole stay of the ICU. And as a result, this is something that we got in this COVID trial, and we are just publishing these results now. The time to oxygen free was reduced by 8 days. So oxygen free days, which means that the patient entered the ICU and was intubated until the time that he was extubated and then free from oxygen, because sometimes in COVID patients, many times they could stay only 1 week in mechanical ventilation, but they stay with 2 weeks needing supplemental oxygen. And this is very troublesome because the patient cannot go home, at least in Brazil. So the time that they enter the ICU until the time that they were free from oxygen, we could reduce this by 18 days by applying this PP strategy. Why we use this outcome? Because I knew from the previous study, the successful study in postoperative cardiac patients, that this is the most sensitive outcome for showing an improvement in lung function, because it's something that is really measuring how much you recovered your lung function. And so this is another way of measuring. It's a outcome called oxygen-free days, because in this case you give -1 if the patient dies, and then he doesn't have any free days of oxygen, and then we have a significant difference between the two groups. So we improved the oxygen-free days, and certainly we did not increase mortality. Otherwise, this index here would not be significant. So the future. I think we should always think about interventions to decrease driving pressure. We should think about predictive enrichment. What is predictive enrichment? Nowadays there is these two, let's say, new words. One is prognostic enrichment, and the other one is predictive enrichment. What is the difference? The difference is the following. Prognostic enrichment is that, I'm going to choose for my trial patients with high mortality. Why? Because then, if your strategy improves mortality, it's easier to show a difference if baseline mortality is already 50%. But for instance, if you're going to start a study with a baseline mortality of 5%, you have to randomize millions of patients, right? So, but this is prognostic enrichment. So the problem with prognostic enrichment is that maybe your treatment improves lung condition, but in a very large scale, but the impact in mortality is low because the patients are dying because of other factors like renal failure. So prognostic enrichment is not a very wise way of doing trials. But predictive enrichment is different, because predictive enrichment means I'm going to target a specific population that benefits the most. For instance, if I'm going to treat lung cancer or breast cancer, I'm going to choose patients with a positive receptor of estrogen, and then I'm going to give an antibody targeting these receptors. So if you're going to do a high PIP study, you have to be smart. So let's choose obese patients. Let's choose patients with high driving pressure, because these are the patients that you are really improving the chances of having a positive impact. Certainly you have to individualize PIP, because it's impossible to look to a specific patient and guess how much PIP the patient needs. And it's proven that it doesn't work to look at the X-ray and doesn't work looking at the oxygenation. These are two very bad, let's say, ways of assessing how much PIP your patient needs. And something that if we have time to talk, but this is some trend in the future, you have to individualize your tidal volume based on driving pressure and individualize sedation also. And if we have time, we can talk a little bit about this, because this is a hot topic nowadays. Just to give you an example, first, we are using less and less opioids in the ICU, and opioids was already a good improvement over benzodiazepines, but opioids, now we know that they are very bad for assisted mechanical ventilation, and then we are trying to minimize as much as we can opioids and using much more propofol. And we are looking for new drugs, and maybe inhaled sedation is going to be the future. We don't know yet, but it's something that is being studied. And that's it. So I think there is a very important role for new study. I'm very optimistic that new studies using a new strategy to set PEEP is going to have a higher chances of success. And as I showed you, I had already a very hard time during the low tidal volume strategy. So it was very difficult to prove that low tidal volume was good. And the PEEP is just a harder story, but still I believe that we are going to prove that there is a good PEEP strategy for your patients. And I especially believe in this idea of assessing recruitability, because it's a good way of doing predictive enrichment. So if you do the maneuver and you check that your patient has more than 50% gain in compliance, you can be sure that this patient is going to benefit a lot from a higher PEEP strategy, and especially a higher PEEP strategy in combination with a recruitment maneuver. Okay, just I should finish my presentation here, but I would like to say give me just 1 minute that I would like to present the preliminary results of this study. This is a multi-center study to assess recruitability in patients with ARDS, but then pandemic came, and then basically the first 150 patients, they are all with COVID. So this study, the first part of this study is recruitability in COVID. What this study showed, and as you can see, the highest pressure here was 24 plus 15 of pressure control ventilation, which means that these patients, they had a highest airway pressure of 40 centimeters of water. In some, when the patient was more obese, the highest inspiratory pressure was 45 centimeters of water. Using this strategy now, 0 cases of pneumothorax, 0 cases in all centers. So no single case of pneumothorax. And this is the final results. You see, this is recruitability. So this is a histogram, and you can see that 1/3 of the patients, they had high recruitability above 40 to 45%. The results are very different from previous studies. So this is the original study of Gattinoni, trying to say that the average recruitability is just 13%. Then we have this study of Proti that was suggesting that was only 24%. And then this is the result of the current study. So the median is 32%. So which means that when you have a median of 32, this means that at least half of your patients, they have more than 1/3 of the lung close, and you can recover this. So more than 1/3. So certainly using a kind of recruitability assessment is going to identify at least half of the patients that you can recruit more than 1/3 of the lung. So this is a lot. And this means that you can very easily recognize patients that you can reduce driving pressures by 4, 5, 6 centimeters of water, and this represents half of the patients. So it's a very important number. And then how much PEEP, this is an interesting information, how much PEEP you need for the highly recruitable patients and for the low recruiters. 16 and 10. So no more than it's no single case of PEEP above 20, okay? No single case of PEEP above 20. The average was 16. So if you identify a highly recruitable patient, very likely your average PEEP is going to be around 16. And then you're going to be optimizing the best lung mechanics. Look at the difference in overdistension. If you take these patients and you apply a PEEP of 24, for instance, according to the ARDSNet table, you are going to cause 70% of hyperdistension. But if you have the highly recruitable patients, overdistension is only 30%. So it's a big difference because this patient is going to receive a high PEEP, but will present very little overdistension. And now someone was asking me about the recruitment to inflation ratio. And I put here in parallel, so the recruitability in terms of, so according to this recruitability, either using EIT or using compliance to assess recruitability, you come to these 3 classifications, okay? And then I put here the recruitment to inflation ratio that you can measure according to the procedure described by Laurent Brochard, right? And as you can see, there is a big overlap. Look at this intermediate recruitment. Let me put here. So this is the mid, high, and low, right? So you see this goes from 0.54 to 0.95, which overlaps with this category here. So I think the recruitment to inflation ratio is a good index, but has low specificity and low sensitivity to detect the recruiters. So I prefer much more to use EIT or gaining compliance to do this kind of assessment. And I think this is the main message of this study. So let us finish here, and I think we should we make a pause or we start some discussion. You, Mr. Chairman.
Thank you very much, Dr. Amato. Definitely, it was a very enlightening, and I personally learned a lot from it. And the lecture of Dr. Napplika and Dr. Amato complement each other. I know you're all excited with your questions, but let's have a quick break, bladder break, and some tea and coffee, as well as snacks are served outside, just outside the corridor, and we'll resume in exactly 15 minutes. For those who would want to also have a look of our ventilator or of our NKV 550, there are stations outside and in front, so you may want to look at them as well. Thank you so much. So we'll resume exactly in 15 minutes.
To our lovely classroom, I hope that everyone are excited to have the wrap up and discussion with Dr. Amato. We will have 2 hours for wrap up and discussion. So I urge all of you to please use your microphone in front of you to ask the question. Your question will not only answer your question but may benefit to others as well. All right. So So Dr. Amato and Dr. Napplika, I hope that you don't mind. We will be having a lot of questions from the attendees, and then we will do the wrap up. We will do the discussion. If you have any concern, any interest, or any question, please feel free to raise the question. That will be the important topic for all of us. Thank you.
Okay, so good afternoon again, everyone. And the floor is now open for any questions, clarifications, or insights with regards to the topics discussed by our two experts, Dr. Amato and Dr. Napplika. So the floor is now open. Please feel free to ask a question. You can open your microphones. There's also a microphone at the back. For those who are in our audience staying at the back, you may approach the microphone and ask the question yourself. So again, any first takers? Please feel free to use your own mic. Yes, Dr. Faisal. Go ahead.
Yes, thank you. I'm asking just starting discussion. So because I think this is the best time to Prof. Amato, I'm interested in that your results. The first is there is no complication with barotrauma with recruitment maneuver. Because my experience, maybe we have a different population in Indonesia actually. From my side and my friend, some patient we have some complication like barotrauma exactly. Maybe we want to know how was your management or strategy that you did in the recruitment maneuver. And then I agree with the Napplika said that we have to know what the population possible to recruit. And then, but the problem is when to maintain after we know the like the plateau, the PEEP, ideal PEEP, and the driver pressure, and until the maintain the patient 24 hours and next, and the second or third day we found some barotrauma. Do you have any comment?
Hello. Is it still possible to have some slides? Just 1 second. So everyone that was dealing with COVID saw at least one patient like this, right? Pneumomediastinum, or even some cases like this, right? So a hypertensive pneumomediastinum and emphysema subcutaneous. This was, in fact, they measure. Look how many papers about this. They measured at least 5 times higher incidence than conventional ARDS. And then the key question is, what is special? And then some people was talking about, oh, they have a more fragile parenchyma. Absolutely false. No, not the case, because my experience is exactly like yours. Pneumothorax is not in the first day, it's later on. Look at this. First of all, most cases of pneumothorax or pneumomediastinum happen during high flow nasal cannula, no mechanical ventilation. So COVID is blue, ARDS is yellow. So even during high flow, they have much more pneumothorax. And many of them, they happen 2 to 3 days later. So after 10 days. Even during mechanical ventilation, also it's very few of them happen in the first day. So many of them, it's after assisted mechanical ventilation. So, and then, which is the reason for this? And the reason, I believe, is in this slide. The slide here is the following. So this is the response of volunteers. This is the alveolar PO2. This is minute ventilation. And this is the curve for volunteers. So we have a very bad ventilatory drive related to hypoxemia. Why? Because we only respond when PO2 is below 60. From here to here, there is almost no response. At least this is common in the normal population. But what they found is that COVID patients are like this. Not only this, they are like this. Which means that they have very high ventilatory drive, much higher than common ARDS. And this happens for many days. Which means that typically the problem is that barotrauma is related to the fact that they are under assisted ventilation. Is when they started to make efforts on top of mechanical ventilation. It's not our recruiting maneuver. It's what they are doing later. And something that this is interesting. Look at this slide. This is a patient, 70% of FiO2, and here saturation was 94%, okay? So someone is going to change. Let's see, just P.1 is 1.4, okay? 1.4, P.1, minute volume 9.3. Now we are going to change FiO2. 1 second, to 40%. And the saturation was now 90%, not hypoxemia, so 90% saturation. Takes 4 breaths. Now look at the next breath. Oops, double cycling. Now tidal volume is increasing. Look, it's almost 500 mLs. Minute volume is already 10, so respiratory rate increase. This is signal of expiratory muscle activation when you see this bump. This is expiratory muscle activation. Minute volume is 12. Tidal volume is 500. 13 of minute ventilation. Let's see P.1 now. 6.7. From 1.5 to 6.7 just because we changed FiO2. And this is happening in many patients with COVID. And then we are afraid about using excessive oxygen, but then we forget that these patients, they have a very high ventilatory drive. And then what happens is that it's very easy for them to do, like I say, self-inflicted barotrauma. It's ventilator-induced lung injury. And this is why I believe that most of the COVID patients, they have barotrauma when they are starting to do spontaneous ventilation. And we have to be aware about this. And typically, and also something that I really ask you to pay attention, minute ventilation. Because typically, sometimes we look at the patient, we see 15 liters per minute of minute ventilation. This is normal. It's never normal. 15 minutes, you are not doing protective ventilation because it is the combination of driving pressure and respiratory rate that matters. So if you're having a high minute ventilation, it's a signal that you are causing a lot of injury, and this patient has a very high drive, and then maybe you should be changing your sedation, changing something, or even the FiO2. You can play with the FiO2 and check. It's not all patients that are sensitive to a change in FiO2, but at least 30 to 40% of them, they calm down the ventilatory drive if you give a little bit more of oxygen. Okay, this is, so I believe that the many cases of barotrauma were related to the ventilatory drive and not to ventilator settings that the physician adjusted. But then you have to understand, is it safe to keep a high PEEP level or not? It depends pretty much on each patient. Something that we know nowadays is that just because you are laying down on the bed, you may have decubitus atelectasis. And then, because remember that we needed high PEEP even in patients with normal lungs during anesthesia. So just because the patient is lying down, some patients, because they are obese, they need 15 of PEEP, which means that we are not doing the same strategy as before. For instance, in the old times, when we reached a FiO2 of 40%, we would decrease PEEP until 5 and then extubate. Now we try to reduce just gently the PEEP at the end, but no less than 10 centimeters of water. And then we extubate directly. Because we put the patient under CPAP of 10 and then we extubate. Because under this way, when the patient is extubated, he doesn't have remaining atelectasis. But you have to pay attention that we are not using pressure support of 5 plus 10 of PEEP, because then you are helping too much the patient. I'm talking about a patient that he's ventilating on CPAP of 10, and then you extubate under non-invasive ventilation with the same CPAP level. And using this strategy, we were more successful in having the patient free from oxygen. That's it.
Questions from the floor? Please feel free to ask questions. Yes, doctor.
Hi, I'm an intensivist from the south of Thailand. So my question is about when you decide to paralyze or not paralyze a patient, how would you quantify, I guess, the contribution of spontaneous breathing to compliance?
Oh, this is a very good question. Let me see if I have a slide here about this. One second. Okay. This is more or less what we did. I think basically, just before talking about this, let me just create it. Let me give you this. Okay, let's discuss this topic. So, this is a special study that we are doing, and some features for the future in electrical impedance tomography, that we are using artificial intelligence to estimate esophageal pressure. Okay, so in yellow you have esophageal pressure, so it's the total muscle pressure. So this is airway pressure, this is flow. Here again we have the airway pressure, and then here is the muscle pressure. So how much force the muscle is doing. Let's see how it works. So we are in the same scale here. It's a scale of centimeters of water, okay? This is pressure support level. So you can see that the breath was triggered by the patient that started a little bit before, right? And this is the muscle pressure. In this case, we can see that the muscle pressure is 20 centimeters of water, and pressure support was just plus 10. So in this case, the total driving pressure is 30. And when I see a situation like this, I know that I have to do, I'm much more concerned with the yellow component than with the white component. And then in this case, I would think about, for instance, let's give a little bit of propofol. Okay, let's think about another case. Oops, sorry. Let's think about this other case here. Oh no, this is the same case. Now think about this other case. So now I have here the muscle pressure, and this is the airway pressure. So in this case, muscle pressure is 10 and airway pressure is plus 15. So in this case, the effort, I like when the effort of the patient is between 5 and 10. And then in this case, the physician was doing too much assistance. And then in this case, I would just reduce the level of pressure support. Okay? In this case, it was assisted pressure control ventilation, but pressure support would work the same. So the key question is how, in this case, I had artificial intelligence to measure, and I had a EIT. But how to measure this at the bedside? We are doing lots of studies together with Ewan Golliger from Canada. And I strongly advise now to use the expiratory, the P occlusion. And why this? Because we realize that measuring P.1 doesn't work very well. Why? Because we have too much acquired weakness in the ICU. And then what happens is that when you have muscle atrophy, sometimes your P.1 is high, but the effective pressure, which is you measure by P occlusion or by artificial intelligence, is low. So then for me the priority is to protect the lung, and then if the effective muscle pressure is low, I don't care. And I realize that P.1 is not good for lung protection. So then we use P occlusion, we use that kind of multiplication factor, which is 0.75 to measure P occlusion. So in this protocol for COVID patients, we are measuring P occlusion every single day. And we confirmed that the P occlusion was working because we paralyzed the patient many times to confirm that we are really measuring the driving pressure in the proper way. Now let's just go, now that we have this introduction, let's just finish with that slide, which is this one. So the global strategy is to avoid a high driving pressure, but you have to remember that the total driving pressure is what you set on the ventilator and what the muscles are doing. Something very interesting, and I like this approach, is to know how much compliance the patient has. Because then, and this is something that we did in the protocol, every single day we measure compliance in a condition that the patient was paralyzed. I like to use succinylcholine because it's very quick. And then if you know compliance, you can just divide tidal volume by compliance, and then I set the lowest pressure support, or in fact, I titrated pressure support, because sometimes with 5 of pressure support, I had a lower tidal volume than at 0 pressure support, because the patient was a little bit more comfortable and then was having a lower tidal volume at 5. So I titrated pressure support to give him the lowest possible tidal volume. From 15 of pressure support, I go down to 0. And sometimes many patients I kept at 0. Was the lowest possible tidal volume. So first. Second, never stay, if you are under assisted ventilation, your pH has to be under control. It's impossible to have a calm patient if he has acidosis. So even if you have permissive hypercapnia, you have sometimes to give a little bit of bicarbonate for him to have a normal pH, because then he can relax and having a lower drive. So FiO2, I have showed you the example. So sometimes I titrate. In how much percent of the patients this works? 1/3. So in some patients they have really a high drive related to FiO2. PEEP. To optimize PEEP can reduce your drive because of the Herring-Brauer reflex. But if you are above the ideal PEEP, you are going to increase the dead space, and then the patient is going to increase the drive again. So, but you have to test. Sometimes I try to increase a little bit the PEEP and the patient calms down. This is especially true during non-invasive ventilation sometimes. So sometimes you have just to test and check what happens. But you have to keep an eye always in the tidal volume. If you increase PPR, your tidal volume increases. Again, it's a signal that maybe I have increased dead space, higher PCO2, and then when nothing of these works, then I give more propofol. And if nothing works, even with propofol, I do partial paralysis. And partial paralysis is something that it's very tricky because you are always afraid that the patient is awake and you are doing partial paralysis, right? So then I propose two things that have been very helpful, and we are collecting data to show that no patient remember about the partial paralysis, which is extremely important. And what we are doing is that for every single patient we use the BIS, and I use a parameter that is very, very, very precise parameter, which is respiratory rate. Suppose that you are under pressure support and your respiratory rate is 15, okay, 15 respiratory rate, but you measure occlusion pressure and the occlusion pressure is 30. I can tell you for sure, in this patient, giving more propofol is not going to work. Whatever drug to sedate more this patient is not going to work. What you have to do in this case is to set to partial paralysis. And then you can think, oh, but then, and what if the patient is awake? If the patient is awake, the first signal is that he's going to increase his respiratory rate. But if the patient stays with a low respiratory rate, you are 100% sure that he's not awake. So respiratory rate is a good signal for you to titrate. When you have already a low respiratory rate, but it's still a very high drive, then I give partial paralysis. But for instance, let's suppose the same thing. Occlusion pressure of 30 and respiratory rate of 30. Then I give more propofol. And then this is the rationale. So respiratory rate helps you to give either a little bit of paralysis or propofol. And it's interesting because we are collecting data now that we are giving less sedation when we started to do partial paralysis, because in the past, whenever we had a high P occlusion, we would give more sedation, and it was not working well. And then having this partial paralysis allows you to give a little bit less sedation. And there is something interesting, is that we are collecting data about ICU acquired weakness, and we could show that there is correlation with days of sedation and days in the bed, but not with curare, with paralysis. Interesting. So it's the first signal that, okay, maybe paralysis is not the culprit, it's not the bad thing. The bad thing is sedation and the number of days in the bed. It's very preliminary, but it's something that is being investigated. That's it. Yes?
A tiny question. Do you
Please?
usually see any compliance loss when you switch to paralysis compared to pressure support ventilation?
Ah, this is a very good question. Okay. Okay. Okay, let's start with this slide. Okay, this is this paper I mentioned before in the presentation, Respiratory Drive, and it's a very nice paper. And this paper is showing here something that is very interesting for us to understand. So this is PCO2. This is respiratory rate. This is tidal volume, and this is minute ventilation. Okay. So look at this. They are telling us that there are 3 phases. 1, 2, 3. So what is the first phase? Okay, PCO2 is normal. Then PCO2 is increased, and then look at this. First you increase tidal volume, but respiratory rate is low. And then you cannot increase tidal volume any longer because it's not, it's very costly energetically. And then you start to increase the respiratory rate. So there are 3 phases. So every patient is like this. So you first increase, you get more dyspnea, you get a higher ventilatory drive. You first increase tidal volume, and then you increase the respiratory rate. This is why we see many times a patient with respiratory rate of 18, but a big P occlusion. Okay. But look, somehow in the middle here, from this phase to this phase, you start to have expiratory muscle activation. It's what happens when we run. You start to have a little bit of fatigue of the diaphragm, and then to help the diaphragm, you contracted the abdomen during the late exhalation, because then you go below FRC, and then you gain, like a slingshot, you gain potential energy for the next breath to have some tidal volume without doing any force with the diaphragm, just because you are relaxing the expiratory muscles. Just for you to understand how beautiful it is to see this with EIT, look at this curve on the top. This is tidal volume, and then we gave a shot of paralysis. Tidal volume decreased. But look what I see in the EIT. I see that the inspiratory tidal volume was here and then decreased, but I see the expiratory tidal volume was at this level here and increased. So this can only represent one thing, is that every breath I was overpowering my diaphragm to go up to here, and then this is the relaxing volume, and then at this point I activated the abdominal muscles to go from here to here, and then my tidal volume gets larger because I'm using both. Exactly. If your patient is like this, you paralyze him, and you are going to increase oxygenation. and vice versa. If you put this patient under assisted mechanical ventilation, he's going to antagonize your PEEP, and then he's going to drop oxygenation. So it's extremely important to access if the patient is using expiratory muscles, because then he's going to deteriorate. We are now doing, this is a study that is going to appear in the critical care. We are classifying the patients based on this response. You give paralysis if it goes up, which is a signal that he was activating the expiratory muscles, or let me show you the two examples. Then I come back to this. Okay, this is a patient that I showed you. You paralyze. Look how beautiful he is. You paralyze the end expiratory lung volume increases, right? And look at the esophageal pressure. It decreases. It goes like this. So, end expiratory esophageal pressure. This is during spontaneous breaths, and this is during paralysis. So esophageal pressure goes down because abdominal pressure goes down, and lung volume goes up. So this patient is counteracting 5 centimeters of water of PEEP. And this is what you should expect. You paralyze and you lose a little bit of volume. So this patient is the natural response. And this patient goes very well during assisted ventilation. And this patient is a very good patient to keep on pressure support. And you see the esophageal pressure is sustained. No increase in end expiratory esophageal pressure. So he was not using expiratory muscle. This is a new problem in the ICU. It's something that we are paying attention, that many patients deteriorate and you didn't know why. And now we understand that this is the problem. How many % of the patients is half and half? Half and half. So half of the patients, they improve during spontaneous ventilation, and half of the patients, they get worse. This is very tricky, huh? And look at this. The increase in end expiratory lung volume is related to the fentanyl dosage. So the more fentanyl or more opioids you give to the patient, more likely he's going to be in a bad shape during spontaneous ventilation because of this. So it's a new problem. We need new solutions. I don't know which, but something that we learn, this effect is antagonized by propofol. So giving a little bit of propofol makes it, so every time you're giving opioids, you have to at least give some propofol together. Then it helps. Opioids alone with benzodiazepines, for instance, it's terrible. Okay, so this is something that we are learning now.
To her first question, some ventilators
Don't allow to do the expiratory occlusion maneuver during the spontaneous breathing. What do you recommend to monitor PMAS? Which technique we can use in that condition?
For instance, there is some ventilators, like for instance the PB ventilator, doesn't have the expiratory pause during spontaneous, but you can do the NIF maneuver, negative inspiratory force, and then it works as an expiratory pause. It's just a little bit. You have to go through different. Try to find in your ventilator. If you don't, we do a video call and I show you the steps. But there is a solution. In this ventilator, you have both, so it's easy to do. Servo is very easy, and new ventilators, they are trying to have both. But typically, when you cannot do P occlusion, you can go the NIF, and then it works in the same way.
Questions? Go ahead.
Yeah, I'm Dr. Sunshine from the Bangkok Hospital. I just want to make sure I understand both Dr. Napplika and Dr. Amato correctly. So when you do recruitability assessment, you paralyze the patient, right? You don't do it on the patient who spontaneously breathing, right?
Yeah, you know, we tried before doing in spontaneously breathing, and there are some publications that are successful, but then I saw one single case that was a warning signal for me. And the problem is the following, is that the patient, if you give a little, obviously the patient has to be with a light sedation, right? And then you can do a kind of recruiting maneuver just playing with PEEP. The problem is the following. Certainly you have to be under pressure control or pressure support, because if you are in volume control, it's a disaster, right? Right. But then the problem is that sometimes the recruitment produces cough, and then you have a very deep cough, and then this can explode the lung. So this is why I always paralyze, because of the cough. Let me give you one example what is cough. So this is the plethysmograph signal in the EIT, and then this is a cough. And then lung volume goes down. So the problem of cough is not, and look how much you see this bump in the expiratory flow. So lots of volume are going out of the lung. So because you are contracting very strongly the abdomen, right? So the problem of cough is not here, is what follows here, because then you are going to be at a low lung volume. This is going to produce a sensation of dyspnea, and you are going to take a deep breath, and then you have breath stacking. This is when you explode the lung. So typically cough is followed by breath stacking. And then you have a huge tidal volume, and this is when you explode the lung. So this is why I now, to do a recruiting maneuver, I paralyze the patient. And if you are concerned about acquired weakness, I recommend you to use succinylcholine. I love to use succinylcholine because it's very short, 15 minutes, and the patient is back to the same mode of ventilation. I even don't change the sedation or anything, or maybe I give a small bolus of propofol during the paralysis, but I like very much.
Okay, and talking about sedation and paralysis, I just want to ask a little more questions. You mentioned bees. Yeah, I'm not sure in Thailand we use bees in ICU very often, even in my hospital, which has many bees, but we still don't have enough. I don't know about Chulalongkorn, but in Brazil you use it in every.
I think at least if you are thinking about doing partial paralysis, you have to, because and something maybe this is correct, because we know that the bees is not a 100% specificity device, right? But it especially works for propofol, and since in this case I like to use propofol as the main sedation, it works very well. So I typically try to keep it around 60 to 70 maximum during partial paralysis, ideally 60 or less.
And when you say partial, what do you mean by partial?
Good point. Excellent. First, I was imagining, no, let's use all the technology we have. So let's get a device for measuring the train of 4 and measuring the degree of paralysis. And then I realized that the best parameter is P occlusion. Because, you know, the train of 4 can be completely down, so you have 0 response, but you are still having a high P occlusion, because the diaphragm is a little bit more resistant to paralysis than the rest of the muscles. So the best parameter is the P occlusion. So you titrate P occlusion, and then you stop there. Something that I learned by myself, because there is no textbook or article to tell you about this, is that rocuronium doesn't work very well. And I know because in my hospital is the most used agent for paralysis, rocuronium. But rocuronium, I don't know, understand very well, because you are using, and then slowly the patient at the same level, and slowly the patient gets completely paralyzed. And then you remove, and then suddenly the patient is back to doing a very big force. So it's not stable. And then we started to use cisatracurium. Then you typically find a very nice spot, precise dose that you titrate. Oh, P occlusion now is 12. I'm going to increase 1 ml per hour, and then gets to 10, and then I feel happy about this. So it's very stable doing with cisatracurium and measuring P occlusion.
Maybe my last question. So what we all of things that we talk about are about patients who are supine. Then what happens when you flip the patient? What is the driving pressure that you would use? And would you do recruitment maneuver in prone position patient? And a little bit extension of my question is, and on ECMO.
Wow. This is a lot of questions, but very important questions. Very important. Very important. So, let me show you some more slides here. Oh, 1 second. Okay. First of all, remember that I told you that when you titrate PEEP using EIT, I always choose the crossing point between collapse and overdistension. Okay. Why this? Later on, maybe we have some time to discuss, because this typically produces the optimum transpulmonary pressure. We have now lots of studies showing that when you choose the crossing point, your transpulmonary pressure is +2. That is exactly what every normal lung, or even the diseased lung, they feel more comfortable. Later on, maybe I come back to this point, but this is exactly something that they realize in the EpiVent study. They did a post-hoc analysis in the EpiVent, and they realized that all the patients that used a transpulmonary pressure close to +2, they had the best prognosis. And if you have super obese patients, to be at a slightly positive transpulmonary pressure, you have to use a very high PEEP, because this is patients in Boston. But anyway, we always choose this. You say, so because you have a little bit of overdistension, and you have a little bit of collapse already happening in this lung, but is the, let's say, the happiest condition for this lung. Let's go now. This is the model I use in my lab to produce obese patients. I just put some weight on the abdominal cavity. Okay. What happens with the EIT signal? This is without weight. Collapse, overdistension, crossing point at 5. Now I'm going to put the weight, and the curve moves to the left. So collapse starts at a higher pressure, overdistension. I don't see any overdistension here, because the weight is protecting. And I have exactly the same peak compliance. So everything is just shift to the left. So going back, look, this is a patient normal, and now with the weight. So it's just a left shift of the curve, okay? Now Trendelenburg. 11 goes to 60. So Trendelenburg is equivalent to putting some weight on the belly. And now the most important thing, what happens in prone? In some patients, 14, 21. So this particular patient, he had a very prominent belly, and when in prone, he had a big, let's say, compression of the diaphragm because of the abdominal content. And then to stay in a good oxygenation and a good PEEP without the crossing point, he needed 20 of PEEP, while in supine he needed only 12. So it's a big difference. Oh, but this is for all patients? No. Some patients is the opposite. Some patients, they have more overdistension in prone, which means that they need less PEEP. So, in general, patients need 2 centimeters less PEEP in prone, in average. But each patient should be individualized. You can be 100% sure that when you prone a patient and the patient deteriorates, it's because you have something like this. It's a patient in which the belly is compressing the diaphragm, and then he needs higher PEEP in prone. Okay? So after learning this, what we do, we titrate PEEP again in prone. So we titrate in supine, and then if we prone, we titrate again in prone. But let me tell you another trick that I think for me was the most important one in clinical practice. This is a patient in supine. So you know that patient has dorsal collapse. How do you know? How do you know when you see an image like this? This is the typical image in EIT of a patient with dorsal collapse. You see, the ventral to dorsal ratio is very low. Sorry, it's very high, which means that I don't have dorsal ventilation. So this is a patient that I know that has dorsal atelectasis. Okay? So let's go back. So you have a patient that you know he has dorsal collapse. Then you're going to prone. What do you expect is that along the hours you are going to have some dorsal recruitment, maybe this, and maybe this. Certainly there is a shift of the collapsed zones, and then you are starting to have some ventral collapse. Now you have a problem, is that I'm going to supine this patient again, and you must have this experience with COVID. I remember that with COVID, some patients, they had 8, 10 sessions of prone. Because every time we are supining the patient back, the patient deteriorated again, right? And then we realized something very interesting, that there is a trick that you can do here, which is now you just apply +4. So if the patient is obese, you apply +6. And now you start with some ventral collapse, which is going to reopen, and now this extra PEEP is enough to avoid the recollapse of those zones. And it works very well. And then we also did this because, can you look at me? When the patient was prone, and then when I was resupining the patient doing this, I could see when I used the EIT that this side had more collapse than this side. So only just resupining the patient and putting him in lateral position, and then, so this side here gets more atelectasis than the other side. And then and then using this maneuver, you avoid this. And this decreased a lot the need of a next proning maneuver for this patient. So this was something very interesting. And this was also something that improved my understanding about prone. Because the key question is how much time you need to go from this to this. And this needs a recruiting maneuver or is going to happen spontaneously? This is an important question. Okay, let's move on. Okay, look at this. This CT is from Luciano Gattinoni. Okay, this is a very old CT from Luciano, the first time that he was describing proning. And then he showed that this collapse is migrating. Migratório in Portuguese is migrating collapse. So from dorsal to ventral. The key question is how long it takes and how it works. So we started to do some pig studies. This is the animal in supine. Sorry for the quality of the CT, it's very bad, but there is lots of collapse here. And in prone, 10 minutes after prone, this is still full of collapse. So only, we can see here in the histogram. I'm running out of battery. But you can see in the histogram that there is, look, lots of units, they have the density of collapse. And then only 24 hours later, I got rid. So in this animal, it took 24 hours to reverse. Ideally, now, every patient that is in prone, I like to use EIT because then I put the ventral and dorsal platysmogram. And then this is ventral, and this is the dorsal. And you can see that the dorsal is increasing along the time. Which is the meaning of this? You are gaining aeration. And ideally, you should see gaining aeration and decreasing driving pressure along the time, which is the yellow. So we are following this very much because this is the ideal response in prone. You should always see this. You have to gain aeration, meaning that you are reversing the atelectasis, and you have to see a drop, a progressive drop in driving pressure. So this is the whole night, okay? This is the whole night. Takes the whole night to happen. But some patients, they do this very slowly. And what you have to do? Keep going. So now there is a paper published in Chest. Let me see here. This paper, published in December 2022. Prolonged prone position reduces mortality. Which is prolonged? More than 24 hours. And I don't think that this is for all patients, but it's for those that you see a very slow response. And then you know that it takes a long time to reopen the atelectatic areas. So I'm enjoying the prone position more and more because it's one of the best recruiting maneuvers. And so this is why I never use any more than 45 of recruiting pressures, because if I don't recruit everything after achieving 45, I prone the patient. Okay, so there is no need to go up to 60 as in the past, because if you go to 45 and you don't achieve a good result, let's prone. But it's still, I still strongly believe in the idea of using the recruitability test, because it gives you a flavor if it's worth it to go up to 45.
Doctor, we have a phone-in question. Actually, we're also live. So we have someone asking, what do you think of lung recruitment maneuver for ARDS patients on ultra-protective lung strategy?
Yeah, and then this comes back to his question about what about in ECMO? Yeah. I think the ECMO patient is the patient in which recruitability and recruitment is the most important one. Why? For two reasons. First is that these patients are the sickest ones, and they have the largest amount of lung collapse. The second reason is that the lower is the tidal volume, the higher the chances of having reabsorption atelectasis related to low VQ units and high FiO2. So even if you are not using high FiO2 in the ventilator, if you are using the membrane, this also promotes some reabsorption atelectasis because there is no nitrogen in the blood. So reabsorption atelectasis is very prevalent in ECMO. And when we did it experimentally, every single animal that we put on ECMO increased the amount of atelectasis. Okay, then I'm a stronger believer in the idea of using open lung during ECMO. And I think it's interesting because the literature on PEEP for mechanical ventilation is very controversial, but in ECMO, every single meta-analysis show the same. The higher the PEEP, the better the ECMO results. So this is why today we never use 10, 10, 10. So you should 10 of PEEP, 10 of respiratory rate, 10 of driving pressure. We always use at least 15 of PEEP. But then to use more than 15, I prefer to titrate and check how much PEEP I need. Okay, this is for PEEP titration. But let's suppose that I do a PEEP titration in ECMO and my patient is still like this. I could not reopen the atelectasis. Then I'm going to prone in ECMO. And guess what? There are now 3 studies showing that the patient has to be prone in ECMO in the first 48 hours. And this improves the prognosis. Let me show you one study. Look at this. This one, prone position monitored by electrical impedance tomography. And then there is a French study, and there is another French study. The 3 of them are showing that if you prone the patient in the first 48 hours, this is going to be much better. Okay, there is this other study. Let me see if I have here. One second. Oh, I don't, but there is an English study showing the same thing. If you prone the patient in the first 72 hours, this is going to improve in the first 48 hours. So now in my ICU, the nurses already know. If the patient is ECMO, he's going to be prone every single, which is a disaster, right? Have you seen the pronation procedure in ECMO? Ah, it's a nightmare. But it's feasible, and this is why. If I don't have a good blood flow in ECMO, I ask the surgeon to change the cannula, because if you have a bad blood flow, you cannot put in prone. That's it. I hope this I have satisfied our question.
Questions from the floor? From our visitors from Malaysia, sir? You have sir,
Sorry,
go ahead, please.
I have some question about the recruitability assessment. We have a lot of methods to assess recruitability assessments, such as PV gentle suit lung and reflection and inflation index, right? So do you have any recommend which method is benefit for which patient, or should be aware of to use method in which patient?
Okay. This is a very difficult question, okay? Very difficult, a very important one. Let's see if we can come with some intuition. 1 second. Oh, I know where. Sorry. This is why people say that when we get older, it's not that we lose memory, we lose the directory. So we cannot, we know that we have the information, we know where. We don't know where. Okay. I think, just give me some time. It's not this presentation, it's this one. Yes. Okay. Maybe you are. I don't know if you are familiar with these histograms from CT. So in the x-axis, you have the Hounsfield units. 0 means collapse, minus 900 means overdistension. Okay. So this is the histogram. So for instance, this blue lung has lots of collapse. So you have a peak of density, peak of units at 0 density, which means complete collapse. So this animal was at a PEEP of 15. Okay. Then I applied the recruiting maneuver, and then we had this shift. All these above this threshold is the threshold of recruitment. Okay. So when the unit has more air, the aeration is closer. Oh, thank you. It's closer to above. It's to the left, right? So you go to minus 200, minus 400. Here is the normal lung, right? So these units now shifted to these units. When this happened, so these units suffered this shift. You have now look at me. So you have one alveoli that was completely like this, and then it got inflated to minus 400 maximum. So it goes like this. So this is the ideal position to have a very good compliance. But the gain in volume is not that big. So the unit is just like this. Okay, now let's imagine this situation, that I had a little bit of collapse in blue, and then I applied a recruiting maneuver, and then my units jumped to this. Okay? So when this happened, now look at me again. So now you had complete collapse, but now it's boom. Because you are working at high pressure, and these units get completely overdistended already with a high volume. In this case, you gain a lot of volume, but very little compliance, because the units jump from low compliance because they are collapsed to low compliance because they are overdistended. It's a boom, complete jump. So the key question is that for most patients, how it happens, right? And this is why we believe that it's very tricky to use jumping volume to assess recruitability. Because really what the key question is that as I gave you an example, the better the compliance, the more normal is the lung, the bigger is going to be this jumping volume, and then you have a gigantic gain in volume and maybe little recruitment. Okay, so now let's think about the philosophy of each method. If you are using a PV loop and you are measuring hysteresis in the PV loop, you are basically measuring the vertical distance between the inflation limb and the expiratory limb. This is a gaining volume. So PV loop is gaining volume and is subject to this error. Okay, it's subject to this error. recruitment to inflation ratio is based on gaining volume. Let's record. Do you want me to record how is measured the recruitment to inflation ratio? Okay, so let's go. Because then you're going to see that it's a gaining. Oh, sorry, it's really a gaining volume. Oops, I need some power to the computer. Why? Yeah, now it's working. Give me just, sorry. Ah. Here. Okay. Of 6. So this is the maneuver proposed by Laurent Brochard and Lu Chen, okay, published in the Blue Journal. You are at a PEEP of 6, you jump to 16, you have to decrease the respiratory rate to not have auto PEEP, and then you suddenly drop back to 6. So this is the sequence. And I'm showing here the EIT signal together, right? Okay, then how it works. First of all, you concentrate at this part of the curve when you are jumping down from 60 to 6. You have to work at a low respiratory rate to avoid auto PEEP. Then let's suppose that, okay, by definition, I'm dropping 10 centimeters of PEEP. And let's suppose that I'm measuring here in the EIT. Typically, you don't have the EIT, but I'm using EIT because it gets more intuitive. And then I measure that the change in end expiratory lung volume is 1,000 mLs from here to here. Okay, that's it. But when I measure compliance, compliance was 30. I measure compliance here during tidal breaths. Compliance was 30. So the expected change in end expiratory lung volume should be just 300 mLs because it's 30 of compliance times 10 centimeters of water. So this end expiratory lung volume change should be only 300, but I had 1,000. So the observed one, the expected was 300, but the observed was 1,000. So the recruited volume is 700. Now you understand that is a change in volume, which is subject to these kind of errors of, you never know if a unit is recruited and doing boom, or it's just is recruited to a good status. And then, so the recruitment to inflation ratio and the hysteresis of a PV loop, everything is based on volume. And then I believe that we have data to show that they are less reliable than a change in compliance. Okay, so that's it. So I prefer changing compliance, and ideally I prefer using EIT, if possible, yeah.
Questions from our KOLs? Okay, I'll just read a question from our online viewers. This question goes, can one use PO1 as an estimate of occlusion pressure?
Good point. the P.1 is, let me see if I have a good example. No, I don't have here, but let's try to explain theoretically. So basically, you can measure the P.1 exactly in the same maneuver, in the same breath that you are measuring P occlusion, right? So because when you do P occlusion, you are, let's suppose that my finger is representing the airway pressures. You are just about to trigger the ventilator, doing a small inflection in pressure, but then you clack. You close inspiratory and expiratory limbs of the ventilator, and then instead of having this tiny drop in airway pressure to trigger the ventilator, you go to do, and you have the occlusion pressure, right? So if I take just the first 100 milliseconds, I can measure the P.1, and if I take the whole maneuver, I measure the occlusion pressure. And typically, what we have seen is that when the patient has ICU acquired weakness, he can perform this first drop perfectly. But then, this is my normal patient, and my patient with acquired weakness, he can do the first part of the breath and then he stops here and then he starts to... So he has a short version of the normal occlusion pressure. So his P.1 is exactly the same as the normal patient, but the P occlusion is completely different. So the P.1 was a maneuver designed to estimate how much the central nervous system is firing the diaphragm. And this is almost true, except when you have such a degree of acquired weakness that he cannot even perform well in the first 100 milliseconds. But you really need an extreme case of weakness to impair the P.1. But the P occlusion, no. P occlusion, any mild degree of acquired weakness is going to compromise your P occlusion. When we are doing lung protection, I prefer to see and to measure the final result of the muscle activity. So I'm not a physiologist interested in knowing the ventilatory drive. So I prefer to measure P occlusion, because then it's the pressure that is going to damage the lung. And the interesting thing for the latest years is that they could show now that a high P occlusion is bad not only for the lung, but also for the diaphragm. They have measured, and I saw now in Japan. I just came from Kyoto and Osaka, and the people from Osaka University, they have a beautiful study in which they showed that animals with a high P occlusion, they have edema, apoptosis, and neutrophil infiltration in the diaphragm, and also they develop less force. So a high P occlusion is causing damage not only to the lung, but also for the diaphragm. And this is something that you cannot measure with P.1. I think we don't have a good correlation.
One more question was asked and said, please explain more on the use of NIF.
Okay, the NIF is, took me a while to realize how to get to use this trick. Is in ventilators in which we cannot you don't have the inspiratory pause and expiratory pause. And remember that the expiratory pause looks a very simple maneuver, but it's a very smart maneuver, because the ventilator is waiting for the triggering time, and then he performs the occlusion. He cannot close the valves before or afterwards. He has to close exactly, boom, when you have the trigger detection. So it's a very synchronized maneuver. And this is why only the modern ventilators, they can do it. So then you block the inspiratory and expiratory circuit of the ventilator. And so ideally, I think the ventilator should have an expiratory pause, and that's it. But in the PB, they didn't think about this when they designed, and then you have to go to negative inspiratory force maneuver. So it's if I remember correctly, it's a special maneuvers menu, and then you can do NIF, or you can do some other measurements that I don't remember. There are 4 items, and one of them is NIF. And then there it's possible, but that maneuver was designed to. Initially, they thought this was a maneuver used for weaning failure, so that you want to understand which is the maximum force developed by the diaphragm, right? And then you can use this maneuver, but take only the first cycle, not the second or the third or the fourth, like we use for assessing maximum inspiratory pressure. Because typically, when you want to access maximum force of that the patient has for weaning, you wait until because the second attempt the patient does a larger force, larger, and then it stabilizes, and then typically this requires 5 to 6 cycles, and then you have a stable maximum inspiratory pressure. This is not the case. We do it, but we use only the first cycle. That's it.
Any more questions from the rest of our panel? From the back side of the room? Any questions? Please feel free to approach any of the microphones here. So it was a very fruitful discussion. Obrigado, senor.
Thank you for speaking in Portuguese.
Kapon kap. Thank you so much for this opportunity to really have this exchange with you, and us from this region, the Asia Pacific region, is very thankful for this great opportunity. And hopefully in the future we'll get to do more of these activities. To finally close this program, may I ask VP for Sales, Dwayne?
Sorry, I didn't hear. I was showing how expiratory hold
it. Maybe I would like to show one last slide because of all these questions about volume and compliance. Because I would like to show just some. Okay. This is not going to take more than 1 or 2 minutes. So this is again. This is the recruitment maneuver like we are proposing in the ventilator. So you typically use a pressure control, and then the machine goes automatically increasing PEEP and then decreasing PEEP. You can choose something very comfortable. Nowadays, when I go to let's say to a place where people is extremely careful about overdistension, I say, okay, so establish a maximum ceiling point of 30 of pressure, but typically I suggest to go at to a minimum of 35, because I never saw any case of barotrauma with 35 or 40 of pressures in the airways. So I think you can go, and you are going to stay here just for a few breaths. But this is the maneuver, and this is what you see in the EIT. And look how interesting is this. Look at this. So I started at a PEEP of 10. So here I have a PEEP of 15, right? And this is the FRC, or end expiratory lung volume, at a PEEP of 15. Now I'm back to 15 here. Sorry, 15 here. So 15 here, 15 here. Let's check what is happening. First, I have a recruited volume here. but I'm not interested in the recruited volume. What I'm interested is in checking this amplitude, because this amplitude divided by this pressure is giving you compliance. And this is very interesting because it looks simple, but it's not. When I talked with Laurent Brochard for the last 10 years, he's always telling me, compliance is not good to assess recruitment. Why? Because he was increasing PEEP from 6 to 16, and then he observed that in most patients, even the very recruitable ones, compliance deteriorates or just stays the same. So from 6 to 16, even in patients that have very large recruitment, compliance was the same. But then he never taught, he never think about something very smart in this maneuver. When you are increasing from 6 to 16, you are increasing recruitment. Many units may be recruited, and many units are going to be over-distended. And then from 6 to 16, maybe the net result is uneven compliance. But maybe you had a lot of recruitment together with a lot of over-distension. When we use this maneuver, we avoid this problem completely because we are measuring the gain in compliance at the same PEEP. So you take out over-distension of the game. Because I'm going to measure at the same PEEP this compliance and this compliance. So I don't have any over-distension here. I only, and then this is why this tidal volume is larger, because now I have the pure effect of recruitment without having any over-distension. And this is why with this maneuver we get a very specific result. It's just for you to understand why I believe that, and important to keep in mind, because many people believe that compliance doesn't work for assessing recruitment, and this is absolutely not the case. And I can show you that we have just to show you one final slide. When we use in this way, look how good is the correlation with CT data. Compliance gain at the same PEEP, because we want to avoid over-distension, and how much you reverse collapse on the CT. So this result was very well. If I try to do the same correlation with volume gain, forget. That's it.
Thank you, sir, for that additional information. It really helps. Dwayne?
So I think I met Marcelo probably in 1994 the first time. And it's been my honor to be able to bring him to Asia many times over the years. And he and his colleagues in his lab and in his hospital have contributed so much to helping us to design clinically relevant applications for you that hopefully you can experience the value of. But you know, as Dr. Amato is getting older, he doesn't want to travel to Asia quite so much. So this time he got introduced to Phuket, so now he's starting to fall in love with traveling again. So hopefully we can welcome him back in the future again. Dr. Napplika, thank you so much for your contribution as well, particularly in this area of lung recruitment for Thailand. Thank you to our guests from Malaysia and from Indonesia and Korea. And I don't know who all is online. I heard there's around 70 people online. So thank you for joining as well. Thank you to IDS for putting this together. They've been a great partner for us, and I think a great partner for all of you as you work to improve your patient care as well. So again, thank you very much.
So, at this juncture, I would like to thank everyone, of course, our partner IDS, to each partner in the individual countries, PT Indomedic, Gemilang Asia, and Nippon, to the rest of our distributors. Thank you so much. Thank you so much, dear doctors. We really mean our business. That's why we're providing clinically relevant solutions that matter. And hopefully in the future you'll get to know more about this, and we will definitely get in touch with you. In my language, maraming salamat. Salamat datang. Thank you so much for your presence, and we really appreciate everything.
ค่ะในนามของบริษัท IDS Medical System ประเทศไทยจำกัดนะคะวันนี้ขอกราบขอบพระคุณอาจารย์ผู้ทรงเกียรติทุกคนนะคะที่กรุณาสละเวลาอันมีค่ามาร่วมเรียนหนังสือกับเรานะคะแอนดีใจมากๆที่ได้พบอาจารย์ระดับสูงๆทุกท่านเลยวันนี้เป็นเกียรติอย่างยิ่งแล้วก็ขอกราบขอบพระคุณอาจารย์กล้วยไม้ด้วยนะคะที่กรุณามาเป็นเกียรตินะคะแชร์ประสบการณ์เรื่อง Gentle หลังสูตรนะคะ and thank you so much Dr. Amato we really appreciate your presence in Thailand and we hope that you can come more often so thank you ขอบพระคุณทุกท่านค่ะ
As a final closing event, can we take a group picture if that's possible? Yeah. Outside, just outside. Yeah. Thank you.